Okay, I hope all of you had listened to my endocrine lectures there. Before we are going to start our rapid MCQ session, there will be a big lecture series on endocrine. I believe all of you would have listened to that because endocrine is something that's again concept oriented. If you know the concept, it's going to be, you haven't listened that. How to get that lecture? It's available for everyone. Just contact my moderators. After listening to my lectures only, because it's scheduled like that, I believe. And yeah, my endocrine lecture is available. If you're a subscriber, it's absolutely available for you. It's free and you can listen to the lecture. This is an MCQ revision lecture. Okay. Yeah, it is available. And I'm not sure how many MCQs we can do today. I will try my best to do as much as possible. I'll try my level best to do as much as possible. Let's see how much we can do, and maybe like we can go on for another 2.5 to 3 hours from now. And okay, you have access to revision MCQ sessions only. Dr. Ramna, that's a little strange. Like I'll just check. Like just message the moderators. They will help you out with that. Okay. Okay. Yeah, they'll be helping you out because after endocrine lecture only, I asked people to just start with the endocrine MCQ. And Sunday we are going to see infectious disease. That is different. Even you can go in any order because that does not involve much of concepts. That is like you know it or not. If it's a typhoid, if it's a leptospirosis, you know it is a typhoid, you will answer. If you don't know, you won't answer. That's straightforward. That we can do the MCQs simultaneously as you listen to the lecture. But this is something different. Okay. And I also don't want to stuff all the endocrine for you just by today itself. Let's take some time and do. Okay, so that's why we split the lecture into 2 parts. Today I will try to maximum finish another 100 or 120 MCQs. And tomorrow again we'll work out some more MCQs. Then day after we have a whole day for ID and we can just go on with that. Okay, the very first question for you all is here. A 56-year-old lifelong smoker presents to his GP with cough, breathlessness, weight loss. A chest X-ray is abnormal with a mass in the right hilum. The tumor is suggestive of small cell lung carcinoma. Must be wondering, oh my God, why we are having oncology in endocrinology. However you consider, now we have a diagnosis. This is a small cell lung carcinoma. So what result you will find in a small cell lung carcinoma? For that, you should know what small cell lung carcinoma can cause. It can cause a myriad of paraneoplastic syndrome. Among them, one such paraneoplastic syndrome, which I had explained over there, is SIADH. Means what? Syndrome of inappropriate antidiuretic hormone secretion. All right. So what happens in SIADH? Patient will be euvolemic, but sodium level will go down. Urinary sodium and urinary osmolality will be up. So which of the A, B, C, D, E fits that? Which fits that? And that one doctor already has answered. And which of the following? Dr. Dairam has answered, Dr. Tayaba Jamil has answered. They are telling it's B, and the answer is B. This is an SIADH. What will happen? Low plasma osmolality, hyponatremia, inappropriate high urine osmolality, like I said, and high urinary sodium. All right. In the face of euvolemia, patient will be euvolemic. You should know all the 4 points. Very important. Hyponatremia, decreased sodium. Once sodium is decreased, what is going to happen? Your plasma osmolality is going to go down. Why it's decreased? It's going to be high in the urine. It's not in the plasma, it's going to be high in the urine. And also, as a result of high sodium in the urine, the urinary osmolality is also going to be high. Simple as that. This is your SIADH. The next question. 54-year-old woman is seen for the first time in the diabetes clinic. She is obese, plethoric, and has marked bruising on her limbs, fresh striae over her abdomen. She had developed a dorsal kyphosis following a vertebral collapse. Which of the following results help to pinpoint the diagnosis if you suspect Cushing's syndrome secondary to adrenal adenoma? I had already told you the difference between Cushing's disease and Cushing's syndrome in my lecture. A disease is something different, a syndrome is something different. A syndrome is due to an adrenal adenoma. So which results here in the A, B, C, D, E says this is an adrenal adenoma. What happens in an adrenal adenoma? Yes, doctor, you can type here. It would be easier for me. It's what happens in an adrenal adenoma. So many people are after C. Okay, the answer is a bit surprising, I'll tell you. Adrenal adenoma. Let's understand the concepts. Okay, this is not ID. We are not going to rush. What is this? This is your kidney. This is your adrenals. All right. Okay. This is your pituitary gland. Okay. And from this pituitary gland and hypothalamus, this is your hypothalamus and this is your pituitary gland. And from here, your good old ACTH is coming. Okay. The good old ACTH is coming. All right. Okay. The concept is clear now. Your good old ACTH is coming. Okay. So now adrenal adenoma. Okay. Adrenal adenoma will produce what? If there is a tumor, this is an adrenal adenoma. It will produce what? Of course, some doctor has got it. It will produce your cortisol. Right? When excess cortisol is produced by this adrenal adenoma, this goes and gives what here? A negative feedback. What it gives? Already so much cortisol is here. Please, you two don't come over. House full. So what will happen? The ACTH level is going to become undetectable. I hope all of you got it. Nobody should make any mistake in the concepts who are attending my lecture. That is my motto. All right? That is my motto. Okay? Nobody should make any mistakes. All right? So the answer is E. All right? It's E. Okay? The next question. 51-year-old man presents to the emergency with altered consciousness. Okay? All right? Altered consciousness. His BP is low. Skin is pigmented. He has a history of Hashimoto's thyroiditis. His family has been tired. His family says he has been tired for several months and he has been losing weight and he is complaining of abdominal pain. Oh, now what is the diagnosis first before we think what we can find in the investigation? All right, just see the history and altered consciousness. Point number 1, hypotension, pigmentation, weight loss, abdominal pain, and 6, it is associated with the Hashimoto's thyroiditis. So he is having an autoimmune condition which fits everything. Addison's disease. Am I right or not? It's an Addisonian picture. Head to toe, you should know what happens to someone with Addison's disease. This space is learning, that's why it starts from here. There's nothing you're going to go and learn there. You suspect someone with Addison's, what you're going to ask? Sir, do you have any giddiness or dizziness when you get up from standing? Hypotension, postural hypotension will be there. You find any changes in your oral cavity, hyperpigmentation in the mouth, weight loss. And this Addison's disease is associated with myriad of other autoimmune disease. Among them is Hashimoto thyroiditis, autoimmune thyroiditis. It is associated with type 1 diabetes mellitus. It is associated with your good old vitiligo. So any patient who is coming with one finding, you have to ask about all the rest of the findings to rule out. So what happens in Addison's disease? What happens in Addison's disease? The serum sodium is going to be low and serum potassium is going to be high. So what is the answer? The answer is B, serum sodium level of 116. Yes, you guys got it. Now, 31-year-old man is referred to local hypertension clinic because of recently discovered hypertension that is labile and difficult to control. Which of the following feature is likely to suggest a genetic or familial syndrome that is the cause of hypertension? There are a lot of Mendelian forms of hypertension. Okay, lot of Mendelian forms of hypertension. So which of the following things will suggest? So what they are trying to ask you, something associated with hypertension. What syndrome is that? It's MEN syndrome. Excellent. This is a MEN syndrome. So what particular thing here says it's a MEN syndrome? Why it's a MEN syndrome? MEN syndrome is associated with what? Your pheochromocytoma. Especially your MEN2, which we have learned when we are doing the concept lecture. This pheochromocytoma is also associated with, the MEN2 is also associated with your parathyroid hyperplasia. Which of the following signifies that? Answer D. So a family history of parathyroid hyperplasia is the right answer. This is associated, this is a MEN2 syndrome with MTC. Next question. 37-year-old woman presents to the endocrine clinic with history of hirsutism, acne, oligomenorrhea. She has no children and there is no family history of similar symptoms. She is having difficulty losing weight. She has searched the internet and thinks she might be having polycystic ovarian syndrome. She wants to discuss the implications and her BMI is 29. Which of the following is the most important issue to discuss at this stage of her life? All right, this is a typical clinical scenario. All right. What is more important at this stage? This is a case of PCOS. Her BMI is 29. Obviously, she needs to lose the weight. Obviously, she needs to keep an eye on her blood glucose levels. Obviously, she needs to do exercise. Hirsutism treatment, plenty of things are available for hirsutism treatment. All right. Hirsutism treatment, plenty of things are available. You can give lot of topical agents. Now we are in the laser era where cosmetology has stemmed out as a separate branch of dermatology. So among all these things, which is the most important thing you need to discuss in the physician's office? It's not everything. There is one thing, that is B. When she wants to have children, whether she'll be able to conceive, all those things should be evaluated. That's the most important issue to discuss. All right, most important issue to discuss. She's BMI is high, she's an elderly primate. The rest of the things are important, but they are asking what is the most important things. That's the reason I always tell MRCP MCQ options can have more than one right options. But what they expect you to tell is which is the most appropriate one. All the things are right here. She needs treatment or hirsutism. She cannot go out with a beard. Her blood glucose level has to be under control. Weight reduction diets and exercise regimens has to be started. But above all, the most important thing is she needs to know when she wants to plan for a children. Okay. 29-year-old woman presents to the general practitioner with a history of weight loss, heat intolerance, poor concentration, and palpitations. All right. Hypothyroid features. Which of the following is most likely to associated with thyroiditis associated with viral infection? What they're asking? Your classical Quervain. I even showed you picture of the Quervain, and I even told you what happens in Quervain thyroiditis. What happens? Will there be bilateral exophthalmos? Will there be a smooth goiter there? Will there be any positive antibodies? Will there be any pre-tibial myxedema? What I had said you all, what happens in Quervain? There is going to be reduced uptake. Quervain shows reduced uptake. The only treatment is supportive plus you can give one more medication I said, that is your good old NSAIDs. These are the things you can give in a Quervain patient. All right. Next MCQ. 34-year-old woman is referred to endocrine clinic with a history of thyrotoxicosis. At her first appointment, she is found to have a smooth goiter, lid lag, bilateral exophthalmos with puffy eyelids, and conjunctival injection. She wants to discuss the treatment of a thyroid problem and she's keen to become pregnant. Now, what is the most important treatment advice you are going to give? What is the most important treatment you are going to advise? Will you go ahead and do a thyroidectomy? Will you do that? I don't think it's warranted at this moment. Radioactive iodine? No, 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 no. All right. Will you give beta blockers alone? It's not going to help. Beta blockers can give you some symptomatic relief, right? It's not going to do anything else. Do you give antithyroid drugs with thyroxine? That is called block and replacement regime. Just think, will you give that? Or do you give a thionamide therapy? Will you block and release, or you are going to give a thionamide? Okay, we'll block and replace. Thyroxine is required. Are you gonna earlier days, if that is the case, the treatment is going to be your PTU, profile thiouracil. Okay, earlier days, the same thing, same question asked 2 years back, the treatment is going to be PTU. Now we don't do that. Actually, as per the latest guidelines, the answer is going to be B. You'll be surprised. Yes, it's B. I didn't look at the answer, but I'm just telling it's B. All right. This carbimazole and profile thiouracil, okay, are used. Okay, both are used. Especially now also in some centers use profile thiouracil, some centers use carbimazole. Both have their own rationale behind this. I don't support either of it, neither I'm in favor of it, because we are not allowed to prescribe that. This is typically prescribed by a reproductive endocrinologist and along with a consultation with a pediatrician. But typically thionamide therapy is the better option here than block and replace. This block and replace is obsolete now in pregnancy. It's obsolete, never ever do that. In a pregnancy, no. This is a big no drug, okay? All right. 30-year-old man and his wife refer to reproductive endocrinology. Just now we are talking about reproductive endocrinology. After failing to conceive for 2 years, the man admits use of recreational drugs, anabolic steroids in the past. Examination of the man as follows. Height 189 centimeter, weight 95 kg, central distribution of adipose tissue, bilateral gynecomastia. USG shows testis calculated right testicular volume is 10.5 and left is 10.1. What syndrome are they talking about? First come to the syndrome, then we will think. Then we will see what is the right option. What syndrome is this, doctors? What syndrome is this first? Absolutely correct. This is a Klinefelter syndrome. A tall guy, low testicular volume, bilateral gynecomastia, central distribution of adipose tissue. It's obviously going to be your Klinefelter syndrome. So you have to do your chromosomal analysis, 47XXY. All right. Now, 40-year-old woman was brought unconscious to the emergency department. On recovery, she is found to have impaired visual acuity. All right, right visual acuity is gone and left visual acuity is also nearly gone, and low blood pressure, electrolytes are abnormal with low sodium, high potassium, history of amenorrhea for the last 5 years. What you will do next? First, before telling what we will do next, first tell me what it is. What it is. This is a dramatic presentation. Tell me the right diagnosis. What is this? This is a dramatic. She's unconscious. Visual acuity is suddenly gone. Blood pressure is suddenly dropped. High levels of potassium, sodium is low, and she has a history of amenorrhea for last 5 years, and she suddenly developed this. This is an acute neurological presentation with endocrinopathy. What you will think of? Think something has to do with your pituitary gland, your vision, blood pressure. Only, yeah, I gave the answer already. It's a pituitary gland. Will an adenoma all of a sudden present like that? Or something else will present like that? This is a case of pituitary apoplexy. What is meant by the word apoplexy? Apoplexy is bleeding into the gland. Dr. Patel, why it's pituitary gland? Because that's the combine all the findings. Now think head to toe. Her eyes, vision is gone. Her blood vessel, blood pressure is going down. Sodium is going down and potassium is going up. Which one particular organ can be logically responsible for everything? Obviously your pituitary gland, right? Because any bleeding into your pituitary gland is going to go and compress what? Your optic chiasm. Then not just hemianopia, it will entirely impair your visual acuity if the bleeding is extensive. So bleeding is gone, bleeding is there, and sodium levels will drop because pituitary gland does what? It maintains your water imbalance through your posterior pituitary. Sodium is impaired. So blood pressure will falling down. As a result of that, potassium will go up. So which one gland is responsible for all that? That is in your head. That is the master gland. That's a pituitary. So pituitary apoplexy, what you are going to do immediately? You are going to give IV hydrocortisone. All right. Okay. Next question. 47-year-old man presents with a history of polyuria. He has also repeated constipation, fatigue, and poor concentration, and he has a mass in the left lobe of thyroid. See the parathyroid hormone level. What is the diagnosis? Of course, some parathyroid hyperplasia is there. Okay, parathyroid hypoplasia, and also some polyuria. Could it be Addison's? No. Addison's will have what? Increased potassium. This is Dijat syndrome. No. Dijat syndrome is what? Thymus deficit. This is APS. There are no other features of APS. Magnesium deficiency? No. Magnesium is deficient. Which other mineral will be deficient? Your potassium will also be deficient. This is MEN2. All of you got it because we were just discussing about MEN2 in a couple of questions back. Okay. Next question. 42-year-old man presents to his GP complaining of decreased libido. He has also noticed that his shaving frequency is less. On the few occasions he tried to have sex and may fail to maintain his erection to penetration. Visual field testing is normal and no medication history. Serum prolactin level is 2000 and testosterone is 8, slightly lower. Growth hormone and thyroid function testing are normal. What is the diagnosis here? First, tell me what is the diagnosis here. I told you how to differentiate between a micro and macroprolactinoma in the lecture. Is this value significant of macroprolactinoma? Obviously not. Psychogenic impotence will not have what? It will not have altered prolactin value. So you can rule it out. His thyroid functions are normal. So rule out hypothyroidism. There is no features of acromegaly here. There is no features of acromegaly here because the physical examination is normal. Absolutely. So that's rule out. So the answer is microprolactinoma. Excellent. Yes. Many of you got it. Absolutely. 21-year-old woman presents for review. She is concerned on this occasion because she has not had a period for 5 months. She had a menarche at the age of 13 and regular periods up recently. Her BMI is 17. She is a long distance runner. A pregnancy test is negative. Thyroid function testing is normal. What you will consider in this young woman? What you will be concerned in this young woman? Most people, especially people like in the modeling sector or people like actors and sportsmen cannot eat the way we are eating. Today, if I want to have something, I can go ahead and have something I want. But they cannot have like that. They cannot go ahead and eat your KFC just like that. They cannot go and have Turkish ice cream or baklava just like how we can eat. They have restrictions everywhere. They have personal dietitians. All right, personal dietitians. Okay, they go on a long period of even starvation also, especially these bodybuilders. They are put to dehydrated state, especially when they are going to show up, then flex their muscles. So what is going to happen in them? What's going to happen in them? This is going to be functional hypothalamic amenorrhea. So when they are going to go into extreme states of catabolism, this will obviously lead to amenorrhea, but it's functional. But this is functional. She attained age, had menarche at the age of 13. She had regular periods. I'll tell you, Dr. Anam, she had regular periods. She had regular periods. Her thyroid function testing, everything is normal. But only recently, up to recently, her period stopped. And in any case of premature ovarian insufficiency, there will be increased LH and FSH that will be given. And the clue that a person is a runner or the person is an athlete will not be given. Okay, will not be given here. They are asking which fits this woman's clinical picture. Okay, just consider this woman. Of course, premature ovarian insufficiency can present like that, but it will be little different. You won't find these clues. If you find these clues, then it is POI. Otherwise, it's not a POI. All right, it's a functional hypothalamic amenorrhea. Next question, 42-year-old man with a long-standing human immunodeficiency infection presents for review. He has been taking antiretroviral therapy for 5 years and has been relatively free of associated disease. You notice on examination, he appears to have lost subcutaneous fat on his arms, legs, and face, and increased deposition around his abdomen. His lipid levels are abnormal with a raised triglyceride and low HDL. What happens? What happens? Somebody takes a HIV medication. The lipid distribution will get disrupted. All right. I had told you in my clinical pharmacology lecture, you can see lipid distribution is get disturbed. As a result, the fat and the muscle mass will reduce in your limbs and it will go all the way to the abdomen like that. This is called HIV medication associated lipodystrophy, antiretroviral related lipodystrophy. Also, you can find this thing in the site of insulin injection in a diabetic, type 1 diabetic, or someone who is having a full-blown uncontrolled type 2 diabetes and on insulin. You will find a similar pattern. Wherever they give the insulin injection, you can find lipodystrophy. All right. Now, 44-year-old man is surprised to find he cannot easily get his feet into a pair of shoes. He lost over 5 years ago. He goes to buy a new pair and is told that his shoe size has been increased at this age. He searched the internet for an explanation. He's deciding he could be having an acromegaly. GP has not seen him for several years and thinks his appearance has changed. So he's referred to endocrine clinic. What they are asking, what is the first line investigation you will do in acromegaly? First line. What is the first line? No, we don't give insulin hypoglycemia test and all at this moment. That can be dangerous. We can't do C. This is a first line investigation. You don't want to put the patient in, make the patient occupy an additional bed in the hospital for him to sleep and then measure growth hormone. First line is what? Why any doubt? Straight IGF concentration. Measurement of serum insulin-like growth factor is the very first line. Baseline investigation for acromegaly. Then you go do glucose tolerance test, your growth hormone measurements, all those things comes next. But none of them are the first line investigation. All right. Next question. An obese 55-year-old patient with hypercholesterolemia, LDL is 5.2, HDL is 1, well-controlled type 2 diabetes mellitus, HbA1c is 48 millimole per liter. And hypertension has been on a low cholesterol diet for the last 6 months. His latest LDL is 4.8 and his triglycerides are within normal range. In terms of primary prevention, what you will do next? You will add a metformin, you will add a gemfibrozil, you will add pioglitazone, or you will add a statin. What you will do? Obviously statin. Okay, but in my clinical practice, I won't do. Obviously, please don't follow what I'm going to tell now. Okay, but in MRCP MCQ, you give statin. There is a lot of studies that shows, I don't know, still UK, many people are not trusting those studies. It is proven beyond any doubt. Statin can adversely affect your blood glucose. So we don't put statin unless that guy with a type 2 diabetes has developed an absolute risk of getting a coronary artery disease and his HbA1c is completely blown out of control. Okay. My practice, I give saraglitazar. I hope how many of you know what is a saraglitazar? You know this drug, right? It acts on PCSK9. All right. It helps in bringing down your triglycerides. It also helps in bringing down your HbA1c. It is also helps in bringing down the non-alcoholic fatty liver disease in diabetes mellitus. That's the first drug I'll be going and advising a patient on a diet rather than going for adding up statins. All right. Statins, we go only if needed. That's our practice. Even our trust follows that. But MRCP exams, you add statins. He will have some extra 1 or 2 point increase in his HbA1c. Okay, there are 2 statins that doesn't increase. That also I will tell you clinically, it will help your patient. 2 statins that won't tremendously increase HbA1c. Do you know what statins are they? 2 drugs. Who are going to tell me the 2 drugs that won't increase the HbA1c? Anyone in good clinical practice now, seeing a lot of cases updated? No, rosuvastatin will increase. No, not rosuvastatin and atorvastatin. No. How many of you hear of this? Fluvastatin and pravastatin. Yes, excellent. Fluvastatin and fluvastatin. Okay. Please don't think I am giving advertisement for any pharma company. You all should put lipaglyn or saroglitazar. Saroglitazar is a very expensive drug. And one more drug is evolocumab. That also works wonders, especially type 2 diabetes, if they are affordable. Injection costs a lot. It will bring down the blood glucose level, lipid levels tremendously. Because as per the study, if the LDL is going to be less than 70, the plaque in the vessel will start first stabilizing and then regressing. But LDL should be less than 70 for nearly, it should be maintained for 2 years. In diabetic people, this is our study. It is proven beyond doubt. The same study has been taken in many places. Okay. Yes, we will go again. The next question. 50-year-old woman has been diagnosed with pericardial effusion. The BMI is 31 and her hair is thinning on examination. She also reported recent cold intolerance and constipation. You know what is happening there? No medical history, no medication. She denies any viral prodrome. Her sister has a history of autoimmune thyroid disease. She has dry skin, lost outer third of the eyebrows. There is no palpable goiter. BP is 140/90. Cardiovascular examination shows muffled heart sounds. Why there is a muffled heart sound? Because of pericardial effusion, Bextrad. All right. So what is the answer? I don't need to tell. Hypothyroidism, layman diagnosis. 56-year-old lady presents with sensation of choking and difficulty swallowing, large and solid foods. She had a recent endoscopy which revealed no abnormality of the esophagus. On examination, there is a diffuse nodular goiter, but no thyroid bruit. All right, no thyroid bruit. Biochemistry reveals T4 of 16 and TSH of 3.25. What is the next best investigation to assess the volume of thyroid gland? Volume of thyroid. Volume can be determined by only one particular investigation, that is none other than your ultrasound. Nothing else will determine the volume. All right. And dysphagia, why? Dysphagia, you should know what causes dysphagia of solid foods, what causes dysphagia of liquid foods. That anyways, ma'am's topic, ma'am is going to teach you very nicely on those things. The topic of dysphagia, when your gastro lectures are going to come. But know few facts. Solid means some mass is obstructing always. That's how my understanding. That's how we teach for PACEs. And liquid should be always signifying some kind of motility disorders. And carcinoma obviously lead to solid, then to liquid, right? Just remember the few points if you want to. Anyways, 30-year-old man presents with 3-month history of deteriorating physical performance at work, is associated with dysarthria, clumsiness. He looks anemic, he has hepatomegaly, and he has cave rings in the cornea. What do you do next? What condition is this? What condition is this? Yes, of course, the diagnosis is disease. This is a Wilson's disease. Yesterday only we had a Wilson's disease. I just went to catch up some cases for PACEs to bring the patients. I found a guy with ascites and some wonderful residents there written DCLD, ascites, query alcoholic, and query NAFLD. He wrote like that and he went. That's his query. And they did some USG. I went. Along with me, one more consultant who came, who is simultaneously teaching for PACEs. He just saw the case. Even I didn't get the clue. Like I just saw his cornea. Then the doctor just gave me a touch. See his eyes. I saw we got a KF ring. Then we asked the patient, like, you ever drunk alcohol? He's a complete teetotaler. He himself is surprised that his liver is failing. Even his own family members, including his wife, is surprised that why his liver is failing. People have a notion here, like anybody's liver is failing, then he must have got drunk. Not necessarily. He's having Wilson's. Then we made the guy to sit up and just I asked him to keep both the hands approximated, wing beating tremor. Maybe when I'm teaching about Wilson's, I'll show you the actual patient video with my full examination. All right, this is a Wilson's disease. So you're going to measure serum ceruloplasmin level. All right, like I told you in neurology lecture, Wilson's disease is one of the diseases that manifest like your Parkinson's syndrome. 22-year-old woman, okay, comes with heat intolerance, palpitations, unintentional weight loss. She reports a history of viral illness and a painful neck. Do I have to read, or you guys know what is the diagnosis? A viral illness and a painful neck. BMI is okay. No goiter is palpable, but a fine tremor. And these are her T4 TSH values. All the antibodies are negative, and thyroid isotope scan shows reduced uptake. What is the diagnosis? What is the diagnosis? Obviously, this is a Quervain thyroiditis. Also, there is something called Quervain tenosynovitis. How many of you know? What is it? There is something called Quervain tenosynovitis. 40-year-old man with long-standing type 2 diabetes is found to have urinary albumin excretion rate of 400. His diabetes is well controlled. with the HbA1c of 6.5%. His fasting lipids are the target, and he is normotensive. A neurological examination reveals abnormal pinprick and a vibratory sense peripherally. And peripheral pulses are palpable. Creatinine is normal and potassium is 4. What additional drug should be prescribed? What additional drug you will prescribe in this gentleman? Primary prevention. What you will prevent? What is the concerning thing here? What do you think he shouldn't go to? Obviously, he shouldn't develop nephropathy. They tell, see the kidney, diabetic kidney through diabetic eyes. Why? If you find a retinopathy in the patient and he's started to develop nephropathy, the brake should be applied at that point of time itself. And if you want to save the patient, you want to make sure the nephrology consultant in your hospital is not going to get one more patient for dialysis. You have to put the patient earlier on ACEA or ARB plus aggressive exercise regimen plus good diet will save the person from ending up into nephrologist. All right. A patient has a 2-month history of intermittent flushing associated with tachycardia and wheezing. There have also been episodes of profuse watery diarrhea. On examination, the patient has a facial plethora and is flushed. High blood pressure, pansystolic murmur, which is louder on inspiration, keeping with tricuspid regurgitation. What is the diagnosis with a palpable liver edge? Tricuspid regurgitation, wheeze, diarrhea, palpable liver edge. What all going to, what is it, where it's heading to? Absolutely, this is your good old carcinoid syndrome. So what is the thing you will find? 5-hydroxyindole acetic acid in urine. Excellent. 55-year-old woman has a 6-month history of weight gain. She is otherwise well and she takes no medication. BMI is 28. Blood pressure is 170. She has a round red face and slight atrophy of her arm muscles. Renal function test and urine analysis are normal. So what is the diagnosis? It is going towards your Cushing spectrum. What you will do? What is your next step? Of course, what you will do? I've extensively spoke on Cushing syndrome diagnosis in my lecture. The next thing you have to do is a low dose overnight dexamethasone suppression test will solve your problem. All right? Absolutely yes. 66-year-old patient with extensive smoking history is being investigated, suspected of primary lung malignancy. On a recent chest x-ray, he has been complaining of on a recent chest x-ray, he's been complaining of weakness in his leg and upper arm muscles. He describes standing up from a seated position and in combing hair, he has some difficulty. He reports weight gain over the past months and skin appears to be darker than that. His gums appear stained also. He's taking no regular medication. Over the week-long course of steroids, unresolving chest infection. 4 years previously, gentleman received a radiotherapy for head and neck cancer related to his smoking history. So routine investigation reveals a low potassium. An 8 milligram dexamethasone suppression test revealed an 8 AM cortisol level of 199. ACTH is high. So what is the diagnosis? What is happening here? What is happening here? This guy has an ectopic ACTH secretion. Proved by what? A paraneoplastic syndrome. So the answer is C. Excellent. An overweight patient with a type 2 diabetes mellitus is seen in the outpatient clinic. Despite following an appropriate diet, increased exercise 4 times a week, his blood glucose is still not controlled. He has been following an appropriate diet. He has been following in Increased exercise, no control. HbA1c is 50. Sodium is okay, potassium is okay, creatinine is okay, BMI is 29. What drug you will add here? What drug you are going to add? Obviously, B, first line. Do you add B as first line? He is not on any drugs, just think. This gentleman is not on any drug. Obviously, you will be adding B if you are working in corporate hospital and the guy is a rich folk. All right. Do you know the cost of GLP-1 analog? Do you know the cost of GLP-1 analog? How many of you have given the GLP-1 analog? Liraglutide, dulaglutide. It's an expensive drug. Okay. The best thing for him, put him on D. That's the first line. I told you the criteria to add a GLP-1 agonist in BMI less than 30. You will add GLP-1 analog once another drug is started when the patient develops some complication due to his overweight. Could be a coronary artery disease due to excess fat, could be some cerebrovascular disease or something he has developed, some fatty liver he has developed. That's the point of time you have to add a GLP-1 analog ahead. It has a clear-cut criteria I had described there. Here the answer, the first line, in a classical type 2 metabolic looking guy, high BMI, okay, pseudogynecomastia, flabby. Next thing is metformin, okay, because metformin will help in some amount of weight loss. 33-year-old patient has been diagnosed with primary hyperparathyroidism. She also has rise to prolactin levels, which was also recently diagnosed as being a microprolactinoma after an MRI. Her pituitary, GLP-1 insulin can be given simultaneously. It is being given in some hospitals. But I would put GLP-1 agonist and I will see how he is responding and I will add insulin when it is needed. That's what my personal experience, if you ask me. But they do give. All right, they do give. Microprolactinoma, okay, after an MRI of a pituitary. She tells you that her mother and aunt also have a background of high calcium, kidney stones, and cousin has a pituitary tumor. So this is an endocrinopathy. What is the next thing you are going to find? Hyperparathyroidism is there. Okay, hyperparathyroidism is there. And then what is there? There is a prolactinoma, then pituitary tumor, parathyroid tumor, and then what? This is a MEN one. The next tumor you will find in pancreas. Basically, this is a MEN1 syndrome. 46-year-old magazine columnist is referred to GP with history of tiredness and lethargy. There has been no weight loss. GP found the sodium to be 128 and 130 on 2 occasions. With a normal creatinine, calcium, glucose, and lipid profile, the patient herself denies weight loss or polydipsia, but does report that she is an anxious individual. Bad plasma urine osmolality are 255. Low urine osmolality is normal. What could be the diagnosis? She's an anxious individual, they're telling, her sodium is low. What you will suspect here? What you will suspect here? Sodium is low and plasma osmolality is low. But urine osmolality is preserved. She has tiredness and lethargy. This is psychogenic polydipsia. Somebody gets psyched up, somebody gets worked out, somebody gets so tired, they go ahead and keep drinking water. This is psychogenic polydipsia. The lecture I had described very clearly how to differentiate between this, central diabetes insipidus, that is a cranial, and a nephrogenic diabetes insipidus. Please listen to that for more clarity. 28-year-old single machinist who describes herself as being anxious presence because she is concerned about a weight loss, 59 to 50 kg. That is a significant weight loss, right? That's a significant weight loss. Tiredness, amenorrhea, examination reveals pulse of 96 and regular Lying down blood pressure is 110 and standing blood pressure is 92. So there is some postural hypotension. There is a normocytic normochromic anemia. Tendon reflexes are slow to relax. Urea and electrolytes, liver function test, plasma glucose, serum calcium are normal. Potassium is just above the upper limit of normal. 9 am cortisol is 53, normal prolactin and a low T4 and low normal TSH and undetectable gonadotropin hormone level. So where is the pathology here? Is this anorexia nervosa? Will it cause low relaxing reflex and an anemia? What is the diagnosis here? Is there anything that suggestive of anorexia nervosa? Just think well. This is definitely not thyrotoxicosis. This is definitely not microprolactinoma. This is definitely not primary hypothyroidism. You have only two options to look into. Two options to choose here. Which one you are going to choose? So multitude of things are affected here. Okay, multitude of things are affected. She has amenorrhea. What will explain the amenorrhea? A drastic weight loss, postural hypotension, and high potassium, which will give answer to all these things you should think. Of course, your hypopituitarism. Excellent. Yes, this is your hypopituitarism. Think about everything and there will be an answer. All right. Okay. The same patient or some different patients. Okay. Again, another machinist. Weight loss despite good appetite. Okay. I don't know what's there up with the machinist. Again, another case involving them. Palpitations, excess sweating. GP suspects thyrotoxicosis and he confirms by increased free T4 with an undetectable thyroid stimulating hormone level. On examination, she has a normal sized thyroid gland with a suggestion of bulkiness on the right hand side. A technetium uptake scan reveals a single hot nodule on the right lobe of the thyroid with suppression of activity elsewhere. Antibody testing reveals a normal TPO and normal TRAB levels. What she will have with this finding? What she will have with this finding? Thyrotoxicosis. What finding you will have? Is it unilateral exophthalmos, doctor? One eye or will both eye? Will glycosaminoglycans will have a preference to go and deposit in one eye? Will she have pretibial myxedema? Will she develop corneal ulceration right away or it will take time? Will she have periorbital edema? And definitely this is not how they present. You should see both the eyes will have a subthalmus. Pretibial myxedema is not the answer. I'll tell you why later when we are going to discuss on that. Periorbital edema, no. Corneal ulceration, it's the last stage. The lid retraction and lid lag. Okay, these are the first signs due to sympathetic overactivity in a thyrotoxicosis. Sorry, 44-year-old woman presents now to you with a newly diagnosed type 2 diabetes. She reports increased sweating, swelling of hands and feet to the point she can no longer wear her wedding ring. She complains also her sleep quality is poor and she has some snoring. Acromegaly is suspected with insulin resistance. In a patient with hyperglycemia and a suspected acromegaly, which of the following would confirm the diagnosis of acromegaly? Be very clear and be very clever. Okay. Which of the following is the confirmatory? They are not asking you. They are not asking you They are not asking the first line investigation. Confirmatory, everyone answered yes, glucose tolerance test and growth hormone levels. All right. 30-year-old women presents with an 18-month history of polyuria and polydipsia. Her only other history of notice was increasing joint pains and one visit to GP with depression and constipation some 6 months before. Examination was unremarkable. Investigation shows glucose for urea 5, creatinine 80, serum calcium is high. This is serum phosphate levels. Serum parathyroid levels are 6.2. What kind of clinical picture is this? Is it primary or is it secondary? In secondary, what happens? Calcium level will be decreased. I always told you to remember Ca2 plus. This 2 for secondary to secondary, it will decrease. In tertiary, everything will be up. In primary, increase PTH, increase calcium and decrease phosphate. So this is going to be your primary hyperparathyroidism. You see the table there? I explained in my lecture really well. This is not secondary, doctor. Secondary, always remember calcium. How you write calcium? Ca2 plus. Am I right? That's how you write calcium. Always remember 2 for 2. In secondary, the calcium will be decreased. This is how I always remember. It's a simple way of remembering things. Calcium will be always decreased in secondary hyperparathyroidism. All right. Tertiary, everything will be increased. Pseudo-hypoparathyroidism, it has another features. And I also described about all types of pseudo-hypoparathyroidism in the lectures. Okay. So go to the next question. 32-year-old lawyer presents with non-specific symptoms of tiredness. She is dissatisfied with her GP because and arranges a private MRI scan of a pituitary. Blood testing by private physicians reveal normal thyroid function. Cortisol of 560 nanomole per liter, prolactin of 154, and normal gonadotropin and growth hormone levels. A pituitary scan reveals a 0.8 centimeter microadenoma with no suprasellar extension or compression of optic chiasm. The patient's visual acuity is normal. So what you will do here? Just a microprolactinoma, no visual acuity disturbance, no extension, no compression in the optic chiasm. What are you going to do? Are you going to operate? Are you going to start some somatostatin therapy here? Are you going to put the patient on some bromocriptine or cabergoline? Or are you going to start with some radiotherapy here? None of the things you will do. All right? None of the things you will do. You won't do any surgery either. All you have to do here is observe and reassure. Observe and reassure. Watch out for symptoms and get a clear history and ask her whether she is planning for any pregnancy. In that case, you can go for a treatment. When nothing is there, symptoms are non-specific, don't treat. All right? Don't treat. Okay? Don't treat. That's the dictum. Okay. 54-year-old man who had a previous surgery for acromegaly. All right. He is receiving an adjuvant treatment with lanreotide medical therapy because his growth hormone is persistently elevated. That's a growth hormone receptor. Okay, now that's the question. Mechanism of action of lanreotide. What is the mechanism of action of lanreotide? Yes, lanreotide is a long-acting somatostatin analog. So the answer is C, clinical pharmacology. Okay, sorry. The answer is C. It stimulates the somatostatin receptor. Why it is going to inhibit the somatostatin receptor? Somatostatins are needed to act against growth hormone. If the drug is going to go and inhibit that, how it will even act? This is a somatostatin analog. Analog means what? It acts like a somatostatin. So how it is going to go and inhibit it? Inhibition is an antagonism, right? It's not an agonism. It's an agonist. Analog. All right. It's an analog. Because it stimulates the somatostatin receptor, which leads to inhibition of production of number of hormones, including your growth hormone and as well as your glucagon and insulin, everything. It's a statin. No problem, doctor. Okay. 32-year-old. We'll see two more questions and we will take a break. Okay. 32-year-old man presents with unilateral gynecomastia. He had breast reduction surgery on the other side 10 years ago. On examination, he has a sparse body hair in the axilla and pubic regions. 2 testicles are identified. Both have a small volume. On further questioning, we elucidate that he has a normal sense of smell. His blood levels reveal testosterone 4 nanomole low. LH and FSH are elevated. Prolactin is 300, still it's normal value. Okay, LH is increased. FSH is increased. Unilateral gynecomastia. What's the diagnosis here? Really? Androgen insensitivity syndrome? We have seen that in the lecture. See, LHS and FSS is increased and low volume testis. They are telling unilateral gynecomastia because he already had a breast reduction surgery. Just think and answer me. Why AIS here? This is not AIS. AIS won't present like that. Don't present as a 32-year. This is not 11 beta hydroxylase deficiency and all. No. Don't ever overthink. Don't ever overthink. If it is a hypothalamic hypogonadism, why LHS and FSH are going to increase, doctor? It won't come, right? Hypothalamus is dysfunctional. Why LHS and FSH will come? And here the problem is where? Why LSH and FSH are increasing? Gonad is not acting. And the guy has a gynecomastia. And the guy has a small volume testis. We have seen what is the answer. Normal prolactin is there. Answer is yeah, it's a Klinefelter syndrome. Am I right? Yes, it's a Klinefelter syndrome. Why? This is not Kalman syndrome because they give a clue. His sense of smell is normal. Hypothalamic hypogonadism, it's not because prolactin levels are normal and LHS, FSH are rather high. Androgen insensitivity syndrome presents in an entirely different way. Not as a 32-year-old guy with a low volume testis. Never, ever it presents like that. It's not 11 beta hydroxylase deficiency. All these things will lead to congenital adrenal hyperplasia and symptoms related to adrenal gland. Not this. All right, don't make this mistake. 42-year-old woman is referred to the clinic with difficulty to manage hypertension. She is currently taking indapamide, ramipril, amlodipine, doxycycline, and still blood pressure is high. BMI is 25. Ophthalmoscopy revealed chronic changes consistent with hypertension. That is our hypertensive retinopathy. See this investigation. Anything is significant? White cell count, platelet, nothing is significant. Patient is very compliant with medication. There is a significant history of hypertension, hypokalemia, which was picked 2 years ago. You suspect a Conn syndrome. What is the first investigation you will do to rule out that? Conn syndrome, obviously aldosterone renin ratio. What is a Conn syndrome? Hyperaldosteronism. The first thing you are going to do is do an aldosterone and renin ratio to rule out Conn syndrome. It's always going to be the very first line of investigation. So last question, and after this we will take a break and we will be back in another 5 minutes. 38-year-old man presents to GP complaining of palpitations. sweating and weight loss around 4 kg over the past month. There is a family history of thyroid disease. On examination, she has a blood pressure of 145 and pulse of 92. Okay. There is TSH is low, free T4 is high, hemoglobin is okay, white blood cells are okay, platelets are okay, sodium is okay, potassium, creatinine. She has a thyrotoxicosis. Which of the following best fits action and effects of excess thyroid hormone? Does it decreases myocardial oxygen demand? Of course, no. It rather increases because the tachycardia and palpitation will increase the demand rather than decrease. Does it increase prolactin release? Does it decrease heart rate? Definitely not. Lead to increased bone mass? Definitely not. Why? It can lead to rather osteoporosis. Increased prolactin release, it has nothing to do with increasing or decreasing your prolactin release. So the only option is estrogenization. It can increase your estrogen levels. So the answer is A. All right, let's take a break. You can take a break now. And once you guys are back, we can start working out questions in a much more rapid fashion. All right. See you guys. Take a break. We will be meeting again in another 5-6 minutes. Okay. Yep. Yes, doctor, you can type your question. No problem. I'm here. How many hours for today, sir? Maybe another 2 hours, if that's okay with you all. Yes, you can ask a question, doctor. You can just type your question. I'm here, just free. You can ask your question. Hello, doctors. I'm back. How many of you are here? How many of you are here? Yes. And Dr. Amna has a question. Okay, difficult. I've seen people doing notes and notes, past tests, past medicine. I can stick to one or many resources, but then yes, yes, yes. I'll answer your question. Okay. Have you listened to you're the person who has not yet listened to my video, right? Yeah, have you seen our videos? Have you seen our subject videos, like videos on cardiology and neurology? My videos, especially endocrine ID, or have you seen ma'am's video? Okay. No, 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 not the video of COPD or asthma. Did the moderators guided you towards my core concept video, not the core concept video about MRCP subject video? I have a one lecture on cardiology covering end to end. Have you seen that? Please ask them. I think you are made to watch the core concept videos. I think core concept video is I just elaborated a particular concepts that is tested by RCP. Not that video. You can ask any of the colleagues here, they'll be able to tell, because I believe most of the people have watched that. If it's a cardiology, we cover from end to end, almost end to end. I would proudly say more than most people cover, we have covered. Okay, sessions. Yes, that's where I covered. We cover from end to end. And plus, we have a good Q bank. If you watch the lectures, take notes, and work out all the Q bank, all the questions in the Q bank, plus listen to all the rapid review of MCQ sessions, plus if you work out all the past papers, this should be sufficient to crack the exam. I can bet on that. This should be sufficient to crack the exam. If you want to grab something else apart from all these things, apart from the lectures, our Q bank, past papers, maybe you can subscribe to past medicine or something and just go through that just once. If you get time, you will have enough time only to work these things out, because our Q bank is just too wide. And you can do past papers. Past papers are very important. Maybe for the next batch or after that or some other time, we are planning to bring past paper discussion. I'm not sure, because we don't have enough mentors, and I am also stepping out from part 1 and going to part 2 after your last lecture. When is that scheduled? Psychiatry lecture, I think. I'll be there for psychiatry MCQ discussion. After that, I'll be just going for part 2 and I'm stepping into paces gradually. So we are looking for some mentors. Someone will discuss your past papers for you guys. That would be definitely helpful. But even if somebody is not discussing, sit and work out all the past papers. You can avail the past papers anyway. Work it out. So lectures, Q bank, past papers. These are the cornerstones of preparation. So take a note, take notes. Yes, that's where it is. It's under the sessions. It's not the core concept lecture. That is something that's we wanted to cover, because we wanted to bring around 75 lectures overall. It just started last week. I think we have our neuroanatomy and brainstem syndromes, and again soon we are going to have spinal cord lesions, and we are going to have an exclusive lecture, especially. Yeah, you are welcome, doctor. Especially on DVLA. I hope all of you know what is a DVLA, right? They're going to have a DVLA lecture soon for both part 1, part 2 and PACES candidates. All right. Okay. Let's go ahead and see the next question. Okay. 21-year-old medical student presents with recurrent collapses. They have occurred a number of times in association with stressful periods in the wards. Most recently, she has been attached to the emergency department and suffered 2 collapses during cardiac arrest of patients on the unit. Goodness, instead of patients collapsing, she is collapsing. Her father has type 1 diabetes and on insulin therapy. You are on call with overnight and she collapses again. This lady collapses again. Okay. You collect a blood sample that shows low glucose, high insulin levels, and the normal C-peptide levels. What is the inference? Yes, doctor, there are 614 and we discuss all the important ones. Yeah, welcome, doctor. We discuss all the important MCQs, because if we are going to discuss all the MCQs, then you won't be actually left with any MCQs to discuss. So we discuss the important MCQs for you to give a orientation of how to solve. The rest you guys have to solve definitely. So insulin is high and C-peptide is low. So insulin is coming from somewhere else, right? Because insulin always secreted with the C-peptide. That's why we don't measure insulin level. What we measure? We measure C-peptide level, which is decreased in case of a type 1 diabetes. And as well as long-standing type 2 diabetes who are completely blown up diabetes mellitus control. In both the cases, the C-peptide levels will be low. So insulin is high, C-peptide is low, insulin is coming from outside. In a medical student whose father is type 1 diabetic and having an insulin therapy, so it's an illicit use of insulin. Insulin is secreted like this. This is your C-peptide. This is your B chain and this is your A chain. This is your C-peptide. And in between, what is there? Disulfide bond. This is how insulin looks like. So C-peptide should correspond to insulin. If it is not, and insulin is alone high, she's taking insulin from outside. It's an illicit use of insulin. Sulfonylurea, if she takes, what will happen? Sulfonylurea will go and make insulin secrete in the same physiological fashion. So it will increase both the C-peptide and both the insulin levels. All right. Next question. 45-year-old woman is referred to endocrine clinic complaining of a lump in the neck which becomes particularly prominent when she swallows. On examination, thyroid nodule at the base of the neck. Genetic screening of 2 other family members has medullary thyroid carcinoma with red proto-oncogene. Which other endocrine condition will this patient require screening if she is confirmed to have a red proto-oncogene? Which other condition? Red proto-oncogene is associated with medullary thyroid carcinoma. That is in turn associated with MEN2 syndrome. MEN2 syndrome is associated with which other condition here? Obviously, which other condition? MEN2 syndrome. Pheochromocytoma. It's pheochromocytoma. No need to make any mistakes here. It's pheochromocytoma. It's MEN2 syndrome. 62-year-old man is brought to the emergency department with a grand mal seizure along with 2 days of fatigue and drowsiness. He recently underwent chemotherapy of small cell lung carcinoma of bronchus a few months ago. There are no neurological signs. Sodium is low. Potassium is normal, creatinine, hemoglobin, everything is okay. SAADH is diagnosed. Sodium further falls. What is the next thing you will do? Obviously, initially you will keep NPO, fluid restriction. Then if it is not working, it is still going worse. What is the next step I said? That's the first step, NPO. Now the most appropriate, first you will restrict the fluid. It's not working. Sodium is falling. Next thing, of course, your hypertonic saline is the next thing you have to give here. How do you manage SAADH? First, fluid restriction. Not working, you give 3% sodium chloride. That is your good old hypertonic saline. If it's still not working, what you will give? What you will give? If it is still not working, if the question is asking you like that, okay? If the question is asking you like that, if it's still not working out, still the sodium levels continually falling out, even after, okay, even after you are giving your good old hypertonic saline, what is the next drug you are going to give? Of course, vasopressin receptor antagonists, your demiclocycline and other drugs you will be giving. That's how you step it. So the answer is E here. 45-year-old builder is admitted to the emergency department after falling off a ladder. Past history of note includes hypertension, which is managed with ramipril 10 milligrams. An emergency scan reveals a 3-centimeter right-sided lipid-rich adrenal adenoma and the blood pressure is high. So, Potassium is low here. What is the next step to reveal the underlying diagnosis? He has an adrenal adenoma. What are you going to do here? He has an adrenal adenoma. Obviously, we have seen renin-aldosterone ratio. Post BP medication washout. Always remember, you have to stop the blood pressure medication, give a washout of the blood pressure medication. Then you have to start taking an aldosterone renin ratio to further confirm the diagnosis. Next, you review a 59-year-old man with type 2 diabetes. He was managed with metformin 1 gram twice daily and also has a history of hypertension for which he is treated with ramipril. He is overweight with a body mass index of 36. Which of the following is a contraindication for GLP-1 analog? Who's going to tell me? Which of the following is a contraindication for GLP-1 analog? High body mass index? It's not. It's an indication rather, right? Smoking history? It has absolutely nothing to do with that. Background retinopathy? No, you have to give in case of a background retinopathy. Why? Because it helps in background retinopathy. Hypoglycemia, does it cause hypoglycemia? No. What are the drugs that causes hypoglycemia? Your sulfonylureas can cause hypoglycemia. Your thiazolidinones can cause hypoglycemia. Then what else can cause? Your insulin can cause hypoglycemia. GLP-1 analog cannot cause hypoglycemia. It's very rare unless it's so overdosed. It's the gastroparesis. It will make it worse. If there is a gastroparesis, you don't give GLP-1 analogs. All right? You shouldn't give GLP-1 analogs. Again, 19-year-old woman comes to the emergency department following a collapse. She's hypoglycemic. You understand? From colleague, she's accompanied her in the ambulance. She collapsed. This happens around 3 times in the last couple of months. There is no medical history of a part. Her father is obese and diagnosed with type 2 diabetes 14 years ago. You know the answer. Insulin is high. C-peptide is low normal. What is the answer here? What is the answer here? Obviously, this is going to be your insulin abuse. Right. The next question. 39-year-old women with Hashimoto's thyroiditis presents to the clinic for review, managed with thyroid replacement. Okay, she's present to the endocrine clinic for bilateral loin pain. There is a renal calculi. Bicarbonate is low. Potassium is low. Sodium is okay. Everything else is fine. Creatinine is raised. What they are asking. Is she having acidosis? Yes. She's having Hashimoto's. Along with the acidosis, she's having increased calculus. Which RTA will cause increased acid calculus? Is it A? Obviously not. Because what happens in renal tubular acidosis type 4, ma'am will teach that in nephrology. I'll give you some tips. Okay. I don't want to barge in her subject. Renal tubular acidosis type 4 will have one particular thing, that is increased potassium. So it's not. Medullary sponge kidney, that's a congenital condition. It would have manifested way earlier. Polycystic kidney disease, there is a KUB scan taken. If a polycystic kidney disease, the thing will be there in case of a KUB scan. So it's not the answer. It's not the answer. It's not the answer. Chronic interstitial nephritis, it's a chronic condition. Then there should be other findings as well. Nothing is there. This is RTA type 1. Always remember RTA type 1 is associated with stones. Okay. Ma'am will teach you why it is associated with stones. And remember the autoimmune conditions associated with RTA type 1, including your SLE, compulsive vasculitis, and autoimmune hypothyroidism. And also 2 drugs, that is AMB and lithium, all can be associated with RTA type 1. Okay. Here, a 42-year-old woman presents with a mass in neck with symptoms of choking and shortness of breath when she lies down. Past medical history, family history of goiter, mother, grandmother, all had a thyroid resection. Examine, and she has a multinodular goiter. When you get to her, raise her arms over the head, she develops facial plethora. What is that? That is a Pemberton sign. And there is a retrosternal extension of the goiter. Low TSH is there. Anything else is abnormal, nothing is significant. Which of the following would be the investigation of choice in this patient to determine the degree of retrosternal involvement? You just want to know how much the thyroid has grown from behind. The retrosternal involvement. What will give you the clue that how much it has gone retrosternally? There is only one scan. It's chest X-ray. Will a chest X-ray, how you make the patient stand? You see through here or see through here? Like, so to know how much it has gone behind the sternum, you should have a slice view. Which scan gives a slice view? Simple. Which scan gives a slice view? Obviously, it's the CT scan. You take a CT, it will give a slice view. I hope all of you understand. See, if you take a picture like that, you won't know how much it is behind. If you take a picture from this, you won't know how much it behind. You have to take a picture from this angle all around to know how much it is retrosternally extended. Simple logic. That's it. 54-year-old man presents to you with a newly diagnosed type 2 diabetes mellitus. He is also concerned that finger seems to be little swollen. Again, acromegaly. No longer he is able to wear his wedding ring. He recently attended a dentist who commented that he has an interdental spacing. What is the finding in acromegaly? Widely spaced teeth and as well as tongue bite. What they are asking? What is the very first confirmatory investigations? Initial screening test. What is the initial screening test for acromegaly? IGF. They are asking about initial screening test, and it is your good old IGF. That's it. You got it. Okay. 48-year-old psychiatric nurse with type 2 diabetes presents to the endocrine for review. He was diagnosed with type 2 diabetes after having myocardial infarction 3 years ago. He has a history suspected of gastroparesis, but recently has been asymptomatic. Current medication includes metformin 1 gram twice a day, ramipril 10 gram, simvastatin 40 milligram, aspirin 75 milligram. He also takes benroflumethiazide. And he has a BMI of 33. He has gained 7 kg. BP is 135. HbA1c is going uncontrolled. What medication you will add here? What medication you will add here at first? He has a mild bipedal edema. Okay. Okay, he has a bite. Oh no, not the pioglitazone. It's completely contraindicated, not A. Why? He has already edema. Bipedal edema signifying what? He has an MI. Just listen. He has an MI and he has a bipedal edema. A myocardial infarction patient with a bipedal edema, what do you think of? He's in failure, some form of failure. He's in some CCF. Will you give that? No use. Will you give gliclazide to a patient who is already obese? It will make him even obese. Will you give a bedside insulin glargine? It's not required at this level. Will you give a GLP-1 analog at this stage, or will you give a drug that will help in his fluid overload, that will help his heart? Which drug will help that? Your dapagliflozin, sodium glucose cotransporter 2 inhibitor. This will help in CCF. It's a wonder drug for diabetes mellitus. All right, it's a wonder drug. 19-year-old man presents to GP complaining of tiredness, polyuria, thirst, recurrent thrush. He has a family history of type 2 diabetes and with the early onset in the second and third decade, but no history of elevated BMI. His BMI is of 22. No clinical evidence of acanthosis nigricans. HDL is okay. GGT is fine. What else? Nothing is significant. Islet cells, GAD, and insulin antibodies are all negative. Urine and blood ketone measurements are negative. Urinary dipstick shows 3+ glucosuria. What type of diabetes is this? It's Modi. Obviously, I have extensively thought about Modi. And I had extensively, I have covered about the different types of MODY that you should know. This is a MODY diabetes. It's a MODY diabetes. One concept here in this question is wrong. It doesn't mean MODY diabetes will have a proper BMI. That's a very wrong concept. People think MODY diabetes, they look slim. No, it's not like that. I have seen MODY diabetes people who are obese. Only drug that will respond to 90% of the MODY diabetes is sulfonylurea, nothing else. You give sulfonylurea, glucose will come down. Even if you're going to give how much ever shots of insulin, the glucose will rather go high. Their entire thing, pathophysiology is like that. And complications develop little more slowly in MODY compared to type 1 and type 2. All right. You see a well-controlled 58-year-old type 2 diabetic patient who is fasting for Ramadan. He has a background of diabetic retinopathy and currently takes metformin of around 500 milligrams 3 times daily, as well as ramipril of 10 milligram and aspirin of 75 milligram. And what would you give him advice during the fasting? This question all of you should be able to answer because you would have definitely prescribed during the fasting month. What kind of advice you will give? Of course, you just need to change the timing of metformin. Simple as that. This question doesn't need any explanation because every one of us would have altered drugs. Am I right? Every one of us would have altered drugs for the fasting month. You just need to change the timing of metformin. Now, a 19-year-old female gymnast presents with complaining of headache, right, and fatigue. She has no significant previous medical history, but she's amenorrheic. For the past 4 months, she tells you that her menstrual cycle began at the age of 15 and was regular up to past 6 months when she stopped to more competitive gymnastic training. BP is 110, pulse is 55, BMI is 16. Which of the following hormones will be elevated here? Which of the following hormone will be elevated here? LH? Really? What kind of state she would have been? She is aiming for some weight loss because she's a gymnast. Gymnast means somebody has to be thin. She's aiming for some weight loss. This weight loss will lead to what? Catabolic state. Am I right? Yes. This will lead to stress. When physiologically stressed, which hormone is going to be increased here? Estrogen will increase, LH will increase, prolactin will increase, thyroid hormone will increase. None of this will increase under stress. Only one hormone that will increase, that is your cortisol. That's why we advise people not to get stressed because cortisol will not do any good at that point. This is cortisol due to catabolic and starvation state. All right. Okay. Women presents with secondary amenorrhea. That means she was previously menstruating. Prolactin increases with stress. Yes, up to a level. Up to a level. But not significantly. The significant stress hormone is cortisol. That's why we call cortisol as what? A stress hormone. Nowadays in YouTube, we can find a lot of people talking about stress hormone. Stress hormone. What is a stress hormone? It's cortisol. Is it entirely bad? It's not entirely bad because our creator has designed in such a way the same hormone has some positive effects also. But when somebody is going on a starvation, stress, cortisol is tremendously increased. Cortisol is going to be tremendously increased. That's why we advise people against this fad diet and hyper restricted diet for anything. Except one people, if type 2 diabetic people can go on for such a diet, they can recover and go on for a full remission from diabetes mellitus. It's true. If they go on for a good fasting, prolonged intermittent fasting and proper diet involving very less to nil carbohydrates and eating good fat and exercising every day at least for 25 to 30 minutes, a proper exercise. This walking is not a good exercise. It is not going to help any diabetic or hypertensive patients. Okay, for exercise, I'll teach on another day because I don't want to give additional info other than MCQs right now. A woman presents with a secondary amenorrhea and galactorrhea. She has normal visual field. Her BP is 120, no postural deficits. You are concerned that she may be having a prolactinoma. Okay, and her prolactin is above 2000 and she has 7 millimeter pituitary microadenoma. Which of the following hormones would you expect to be low? If keto diet and weight training? Yes, doctor. Not just weight training, high intensity workout is needed. If their heart is fine and they don't have any rhythm disturbance, very high intensity workout, not the walking. And climbing stairs, at least 300 stairs a day, 300 steps a day. Keto diet, weight training with good carbs like fruits and complete cutoff of carbohydrate. 6 months, check their HbA1c, it will drop as good as a normal patient. What hormone will be low here? Just go through it and tell me what hormone is going to be low here. There is a secondary amenorrhea. Which hormone when low will cause amenorrhea? Growth hormone. Why? Why growth hormone? She is having secondary amenorrhea, which will be low. Why thyroxine? Once again, she is having secondary amenorrhea. Think really well which hormone will be low here. Just think somebody is pregnant. Okay. When somebody is pregnant, prolactin will go up. The prolactin will act as what? In a breastfeeding woman, even when she goes and has an intercourse with her husband, she won't get pregnant. Because of what? Now think about the same thing in this question. What makes, okay, high prolactin, what it does? What it does? What prevents her? This will tremendously decrease one hormone, that is luteinizing hormone, which leads to the secondary amenorrhea. All right, secondary amenorrhea. Secondary amenorrhea. It inhibits luteinizing hormone, straightforward. Just these things are more happening in day-to-day life event only, this endocrinology. 56-year-old patient, poorly controlled type 2 diabetes, comes to diabetic clinic. He has a history of hypertension for which he is taking ramipril 10 mg, amlodipine 10 mg. His current diabetes medication is metformin 1 gram twice daily and glycoside 160 mg twice daily. BP is still high. He tells you that he is smoking 5 to 10 cigarettes a day. Fundoscopy reveals neovascularization. What is the next most important step in his clinical management? I am asking about the next most important step. Like I said, this question is one of the example that MRCP MCQ can have more than one right answers. Smoking, stopping smoking is important. Yes, it is important. Adding indapamide to his regime or doxycycline, these things are not going to help unless his diabetes mellitus is going to help. Okay, I will ask you one thing. Stopping smoking is very important. After a neovascularization, if he stops smoking, will it restore his vision or will it reverse or put a full stop to the progression of retinopathy? Yes or no? Obviously no. But still he has to stop smoking. They are asking most important next step. They are not asking what are the right next step. Will transition to an insulin therapy at the moment. If you are going to start an insulin now, is it going to help anything? No. Absolutely not. Only thing that has to be done now is his vision has to be saved. Even if he's going to end up in some dialysis ward, still his vision should be fine. So you have to give laser photocoagulation. You just listen to, you listen about when you are studying about diabetes, about my diabetic retinopathy part in the ophthalmology lecture. There I had explained about diabetic retinopathy and their pathophysiology, how it occurs and how it can be stopped, everything. All right. So you have to refer for laser photocoagulation. That is the answer. Yes. You are drawing up guidelines for the management of oral blood glucose lowering agents for a patient's post-MI. Looking at the summary of the available evidence, which of the following pieces of advice you will give? Post-MI diabetic patients, you must have definitely seen in your hospital settings. What you will do? What you will do? Pioglitazone? No, it causes sodium and water retention and it will lead to heart failure. Metformin should be stopped in all patients post-MI? Definitely not. That's an old thought. All patients should be transition to permanent insulin therapy? Absolutely not. I'll tell you one thing. In a type 2 diabetes, insulin is not permanent if they have a good control over it. There is nothing called permanent insulin therapy unless he's a type 1 diabetic. That's the reason this kind of scaremongering is the reason people are not willing to take insulin when they have to take insulin, especially during stressful period when they're undergoing some surgery or something. We just help the patients for some days, take insulin, keep up the other medications, then you can resume the medications. Should sulfonylurea? No. The answer is D. Why? Metformin in an unstable circulation post-MI will lead to lactic acidosis. And it will further worsen and complicate the myocardial infarction. That is the one particular reason we have to stop your good old metformin because of development of lactic acidosis. 45-year-old man presents to the clinic after being referred by the general practitioner. He complains of recurrent episodes of sweating, lightheadedness, which are relieved by eating snacks. On 2 occasions, patients report he has fainted after missing his morning breakfast. He reports that tiredness and poor concentration affected his ability to work. He has gained 12 kg in weight in the past 3 months. That is significant weight gain. He is fearful of fasting due to the associated symptoms. He finds symptoms to be temporarily relieved by eating. High BMI, high BP, pulse is okay. What are things here? Fasting glucose is 3.9. What is the next most important? Investigation. What is the diagnosis here before we jump into investigation? This is a hypoglycemia. You have to rule out plenty of things here. Okay, you have to rule out plenty of things. Is it factitious? Is it insulinoma? Is it some other thing? So you have to bring the patient and admit the patient in the hospital, observe the patient, monitor him continually. So inpatient 72-hour monitored fast is the right thing to go about. Hypoglycemia. Some mnemonic is here if you want, you can go through that. 35-year-old man comes to the clinic complaining of tiredness, lethargy, hoarseness of voice, and also he is telling he is losing his hair. Past the past few months. HbA1c where, doctor? What HbA1c will tell you? What HbA1c is tell you, doctor? HbA1c is going to tell you your 3-month average blood glucose. How does that helps when a patient is having continuous low blood glucose levels? This is something else happening, and he is also gaining weight despite low blood glucose levels. So insulin is being secreted in this gentleman in one or the other way. Even if his HbA1c is 4 or even if his HbA1c is 14, it's not going to make any difference. So you need to find out what is bringing this gentleman's blood glucose level so low that he often faints. Why he is going to have hypoglycemia, doctor, if he has an undiagnosed type 2 diabetes mellitus? He will going to go in the spectrum of hyperglycemia, even if he's gaining weight. Just think what is going to make someone gain weight tremendously, and also what is going to make someone have a fainting episode. What is going to do that? And the fainting episode is relieved by eating snacks. I had explained that in my lecture. This is called Whipple's triad. What is a Whipple's triad? Hypoglycemia at the time of fainting or any symptoms. The blood glucose, when you measure during the time, it will be hypoglycemic. And if you eat snacks or a sugar-rich food, you will be recovered. So this patient need a serious inpatient evaluation. He might be having an insulinoma. He might be taking insulin exogenously to create some scene or drama. That left and right we will solve this. And I think Monday I have a session for exam going batch. I have a just 30-40 minute session for them. You guys are welcome for Monday also, right? Thank you so much. Good night, and I'll be seeing you again tomorrow. Okay, bye-bye.